Thank you very much for the nice introduction. So, good morning, dear friends. I'm first of all thankful to the Dr. Gyan who has made me available here, and he has done a very good show. I think doing a CME on diabetic foot, which I think is the most neglected part of the diabetes management so far, and it's being one of the costliest management part also of the diabetes treatment. So this is my institute where I have been working as a director diabetic foot and wound care, BLK-Max Superspeciality Hospital. Dear friends, the human feet, they are nature's surprise. They comprise of 26 bones, 29 joints, and 42 muscles. And according to Italian sculptor Leonardo da Vinci, a masterpiece of engineering and a work of art. And what is diabetic foot? First of all, let me tell you, any foot pathology that results directly from diabetes or because of its long-term complications. That is a diabetic foot according to the Bolton. And according to American Diabetes Association, every patient, if he is diagnosed for the first time as a diabetic, you should examine his feet or annually. So every patient should be examined thoroughly for as far as his feet are concerned. Now, what is the need of clinical assessment of diabetic foot patient? Because just to find out who are the high risk foot patient. In diabetes also, what are the high risk foot patient? So if the patient has history of foot ulcer, or he has a prior amputation, or history of claudication is there, or on examination you find there is a loss of protective sensation, and there is a significant foot deformity, which I'm going to enumerate you just now, and presence of callus, even that is also a high risk foot patient, because that are not uncommon. Almost most of the diabetics, they have peripheral neuropathy and they have callus also, callus or common. Similarly, limited joint mobility and the absent pedal pulses, and reduced ABI, of course, and presence of the peripheral arterial disease. So these all are the high risk foot diabetic patients, and you should be careful and should be examined more frequently as and when advised. Dear friend, as soon as the patient enters in your chamber, with the walking of the patient, you can come to know what does he have. That's what neuropathy is concerned. If he has an ulcer and he's limping, that means he has a mild neuropathy. He's feeling pain, that's why he's limping. If he has a big dressing on his feet, but he's moving with ease, that means he has a severe peripheral neuropathy and has no sensation at all. And then if he's slipping his chappal, is unable to wear the chappals, are unable to hold the weight, that means he has motor neuropathy, and of course the foot drop is a sign of motor neuropathy. These are the OPD podiatry kits, which I'm going to tell you later on. I've been using this podiatry chair. This helps you in seeing the each and every angle of the foot. You can examine foot nicely. And as far as symptomatology of neuropathy is concerned, if there is a numbness of the feet, burning feet, or swelling in the feet, if there are pain in the feet, which is not uncommon, the pain in the leg or calf muscle, and then slipping of chappal, patient will typically say that when I walk, I usually slip the chappal, or I have difficulty in wearing it. That's a very common symptom. And you should always ask the duration of the diabetes, because if the diabetes is more than 10 years, then chances of getting peripheral neuropathy is more. And similarly, if the patient consumes tobacco, then that is also an important thing to be noted down. Now comes the symptoms of peripheral vascular disease. The patient has intermittent claudication. I hope everyone must be knowing what is claudication. And if there is rest pain or nocturnal pain in the legs, or the patient complains that looks cold feet. So these are the certain symptoms of peripheral vascular disease. But you should remember one thing, that if the diabetic has this peripheral neuropathy, then because of neuropathy, he might be not able to perceive the pain. So even up to the impending gangrene stage, he may say, no, doctor, मेरे कोई problem ही नहीं. So claudication and the pain while walking or rest pain is not mandatory if the patient has simultaneously neuropathy as well as the peripheral vasculopathy. Now, as you have seen, been studied in medical days, there's a inspection, palpation, correction, discussion, auscultation. But to start with, there is inspection first of all. So in the different changes in the skin, which you can see, dryness and the turgid weight, they are the hallmark of autonomic neuropathy. Nails should be seen. They are usually hard but brittle in neuropathy, and you should see the fungal infection of the nails also. And if there is a loss of hair, that is the hallmark of the vasculopathy. Then the redness of the skin shows, that means there is cellulitis or ulceration can also be associated with it. And web spaces should always be examined for fungal infection. You should remember this. Always, whenever you examine any foot, you should check the web spaces for presence of any fungal infection or the fissure. And of course, calluses and corns are also to be seen. Now, if there is a amputation is really evident, other deformities like hammer toe, pes cavus, pes planus, or flat foot, then bunion, corn, etc., or this peripheral vascular disease, gangrene, etc., will be easily visible. Then, of course, different toe deformities can be noted down. And skin integrity should be seen in form of if presence of any cut is there or any ulcer, cracked heels is there, redness which may signify the cellulitis or fungal infection between the interdigital area and the gangrene of those. Then the sensory neuropathy leads to loss of protective sensation. This is a very important thing to be remembered. And more than 50% of the diabetic patient, they have no sensation in their feet because of the peripheral neuropathy. And as far as assessment of the sensory neuropathy is concerned, for the touch and pressure sensation, we have Ipswich touch test or semi-Swinston nylon filament. For vibration, we have simple tunic fork with 128 hertz tunic fork, or biothesiometer is semi-quantitative way of finding out the vibration. Then for heat and cold sensation, which goes earliest, we have tip thumb stick or the SCP sensitometer. Now, what is the Ipswich touch test? In this, after asking the patient to close his eyes, the examiner touches the first, third, fifth toe, tip of the toe, plus the dorsum of the toe of the both feet. Then, if more than 2 insensitive sites are there, it means neuropathy is there. And it is as sensitive and specific as the monofilament test, but it does not require any monofilament, which is a nylon filament. If it is pressed against the plantar surface of the foot, it buckles at the 10 gram of weight exertion. If patient cannot feel this pressure, that means he has a loss of protective sensation and chances of getting ulcer at that particular site is more. Light touch can be found out with the brush or the cotton. This we have been taught. Then for pain, we have pinprick method. For vibration, as I told you, 128 hertz tunic fork is there. And this VPT or vibration perception test is again very important semi-quantitative way of finding out the vibration. And this vibration seen at the 6 points at the plantar surface, 6 plus 6, and at 2 at the dorsum of the both feet, and sometime on the medial malleoli also. So if the average of all this is less than 15 volt, then it is normal. 15 to 20 is mild, 20 to 25 moderate. More than 25 volt, this reading means there is severe neuropathy. And if the reading of the average is more than 25 volt, then ulcer is 6 to 7 times high. And minded, if it is more than 43 volt, then the chances of getting ulcer at that particular site or in that particular foot is more than 23 times. Then for temperature sensation, we have tip thumb stick. On one side, it is cold, and on the other side, it is not cold. Patient is asked on touching the both ends, whether he feels it or not. Now, another way is a HCP meter, which tells us by the semi-quantitative way of measuring the temperature sensation. Now we come to the palpation. The tenderness should be seen if a particular portion is there. So that signifies there may be underlying cellulitis, there may be underlying osteomyelitis, or deep abscess can be there. We should also note down the temperature of the foot also. By crude way, one is that we touch the foot with the dorsum of our hand. But IR thermometer is also very useful in this because you can do it subsequently just to find out the what is the after the treatment, how the prognosis has been there. So whether the improvement is there or deterioration is there. So IR thermometer is very important tool. Then capillary refill is to find out the peripheral perfusion. In this, you press the tip of the nail. If there is a blanching of the toe, and once you remove the pressure, it should fill the capillary should fill. So it should become again the pink from the white one after pressing. If it takes more than 3 seconds, that means the capillary refill is delayed and chances of peripheral vascular disease are there, particularly small vessel disease. Then comes the goniometer. This is used to find out the limited joint mobility. This angle, once you do the extension of the first this of the great toe, then this angle, if it is more than 30, then it is normal. If it is less than 30, that means there is a limited joint mobility, which is the hallmark of the subsequent diabetic neuropathy. Because with time there is a ligaments also, they get more so calcified or more so rigid, and they give more pressure. That is why there is more pressure under the first metatarsal. As Dr. Gyan has told us, most of the ulcers, they are confined to the under the first metatarsal bone, head of the first metatarsal bone. Then we have to, whenever see a patient of diabetes, you should always put your fingers on the peripheral pulses like this. Dorsalis pedis is present and the lateral to the extensor hallucis longus. Posterior tibial just behind and below the medial malleolus. Then popliteal in the popliteal fossa and femoral in the femoral triangle, center of the femoral triangle. Now we come to ankle brachial index. This is very important, a very simple test to be done. It is done with the help of Doppler probe and sphygmomanometer. This is a manual way, and this is the automatic way of measuring ankle brachial index. And ABI is the systolic BP at ankle divided by systolic BP at arm. And normally 0.9 to 1.3. If it is 0.7 to 0.89, that means mild obstruction is there. 0.4 to 0.69 is the moderate. Less than 0.4 is severe obstruction, and less than 0.3 means imminent necrosis is there. So you should be cautious and refer the patient for the this peripheral Doppler, peripheral vascular Doppler of both lower limb. And if the ABI is more than 1.3, in the diabetic, what happens because of the medial calcification, vessels are not compressible. So that's why it comes on the higher side. And that is the reason that the few books, they mention normal ABI from 1 to 1.4, right? In a diabetic patient. If two or more than two arteries, they are impalpable, then you should go for ankle brachial index. Mind it that dorsalis pedis is absent in 10% of the patients. So if two or more than two pulses are absent, then you should go for ABI. If it less than 0.9, then go for the peripheral vascular Doppler, arterial, both lower limb. And depending on that, you can go for lower limb angiography, different type of angiography, conventional angiography, CT angio, or MR. Nowadays, CT angiography is preferred because it's easy to perform and it's less invasive also, and it gives you a good idea. And at the time of doing angioplasty, one can find out the further detail of the anatomy of the peripheral arteries. And the new modality I want to discuss here is the transcutaneous oxygen tension, which is TCPO2, which provides information about the blood perfusion in the tissue immediately under the skin. It's a non-invasive technique to measure the limb perfusion and tells us what are the chances of wound healing. You should put the different electrodes around the wound. If you have only one electrode, then you should put it proximal to the wound, and then it is measured. If it is more than 55, it is normal. Less than 40 is critical. Less than 20 needs, the patient needs revascularization. So it should be done just before the angioplasty or bypass surgery, and should be repeated subsequently, so that you can come to know whether the whatever angioplasty bypass surgery has been effective or not, and whether the ulcer is going to heal or not. So this is very important tool which we have in a BLK-Max hospital. This type of the graph, we find it. So it starts from the atmospheric pressure and comes down, and it becomes horizontal. At this level, this is the level. Here you see it's the 42 millimeter mercury. Then to find out the plantar pressure, there is a Harris-Met for the static plantar pressure. And there is a dynamic plantar pressure also, where we make the patient to walk. And this is the F-scan, which was there available in the foot lab of the Dr. Shaw College of Podiatry Medicine, where I did my fellowship in Chicago. But it is at the research basis, so it's not being available in India. And with the Harris-Met, we can get this type of impression. On the left side, you will see is the high arch. This is the normal arch. This is the low arch or the flat foot. So this is a very important tool, very simple also, very cheap also, not very costly. And this shows how to measure the dynamic plantar pressure. We make patient walk over the platform, and we get this type of photographs. You can see, and this is a peaks and trough diagram. You can see the higher the peak, you can see here the patient has a callus under the head of the first metatarsal. So as I told you that the pressure under the callus or the cone is 20-30 times higher. So you can see the pressure is higher. Similarly, around the ulcer, you can see here the foot ulcer is there. So similarly, there is a red area that shows the high peak plantar pressure, and the chances of getting further deterioration, further damage to this area there. And if the under the callus, if you find this type of picture, that shows that this callus is likely to get an ulcer underneath. That's all for as far as I think I'll continue with my next talk. Diabetic foot infection. What do you want?
Sir.
Yeah. So after this very important topic, let us start with the diabetic foot infection.
ये सर बाद में था ना सर आपका?
Sorry.
Next था एक.
Yeah. नहीं इसी में continuity में दोनों एक ही topic एक साथ रखते हुए.
Okay sir.
Should I read just now or you want to later on?
Continue कर दें.
Tell them.
Thanks.
Good. So can we get the light switch off? So the diagnosis and medical management of diabetic foot infections. First of all, epidemiology of the diabetic foot infection. Dear friends, almost 60% of the diabetic foot ulcer, which we get in our day-to-day practice, they are infected. And you should remember that the foot ulceration and foot infection are the commonest cause of hospitalization in diabetic patient. So it is not the cardiac reason, it is not the nephrology or the kidney failure reason for which the diabetic patient gets hospitalized. It is a diabetic foot infection or diabetic foot ulcer. And most of the infection, diabetic foot infection, are polymicrobial. According to one study, it is around 55.7% as far as Indian scenario is concerned. And if you look toward the pathogenesis of diabetic foot infection, we should remember that the diabetic patient, they are prone to foot infection. Why? Because there is a triad of neuropathy, vasculopathy, and immunopathy. Over and above, there is a unique anatomy of foot, which Dr. Gyan has already told nicely. 42 muscles, tendon sheaths in 4 muscular layers, along with neurovascular bundle, are tightly packed in 4 deep compartments, which have been elaborated by Dr. Gyan. So they all tend to favor the proximal spread of infection. If you see this way, so there is a suppose ulcer here, which has some infection. So you will see it can spread along this flexor digitorum longus and can go to the posterior compartment. Similarly, if it is at the lateral border or at the base of the fifth toe, it can move along the peroneus muscle and go to the posterior compartment. Similarly, if it is the dorsum of the great toe, it can go along the extensor locus to the anterior part of the leg, and abscess becomes. And if it is at the flexor part of this flexor digitorum longus at the tip of the toes at the plantar surface, so the abscess can come to the medial side of the foot. This is how the infection spreads and leads to abscess above and on. Because number of times it happens that we find that the patient comes with the cellulitis in the calf. And you will find that there is no any source of infection, no any ulcer as well. But if you see particularly very cautiously, so you will find that there is an ulcer at the plantar great toe. At the tip of the great toe, there is an ulcer which has taken infection along the plantar flexor digitorum longus muscle to the posterior compartment. Now, what are the risk factors for diabetic foot infection patients? If I'm going to tell you, if you put a probe to bone test itself, on examination, if you find there is an ulcer and there is a sinus, if you put a metallic probe inside, if it touches bone, then chances of getting osteomyelitis, that particular portion, is 70 to 80%. This is not PTB or probe to bone test positive. And if ulceration has been for more than 1 month, that is also high risk factor for infection. History of recurrent foot ulcers are there, or a history of trauma is there. Presence of peripheral vascular disease of the affected limb is there. Previous lower extremity amputation is there, or loss of protective sensation, which makes any patient to get vulnerable to get any ulcer formation leading to diabetic foot infection. Then presence of renal infection also reduces the body immunity, leads to a diabetic foot infection. And history of walking barefoot. This is also very important. You should always ask the patient, if you get any plantar ulcer, because walking bare feet is a very common thing, particularly in the south part of the India. Northern part is not so common, but still you should always ask, because one wrong notion is also there, which everyone of you might be knowing. Diabetic patient told कि नंगे पैर घास पे चलिए, so उससे आंखों की रोशनी बढ़ती है. This is a totally wrong notion, and number of times they come to us with the ulcer, then gangrene and other things. So be careful. Now, the microbiology of diabetic foot infection. As per one Indian study, 55.7% are usually polymicrobial. Say, let me tell you, the American or the Caucasian wounds and Indian wounds are a little bit different. Caucasian wounds are usually, they have gram-positive microorganisms, say particularly Staph aureus, Streptococcus epidermidis, and Enterococcus species, and other. But Indian wounds are usually gram-negative. Most of them, as by this study also, like Proteus mirabilis or E. coli, Klebsiella. Then Pseudomonas also is not uncommon in Indian scenario. Then, of course, being a polymicrobial, anaerobes are also make a very important part of the number of diabetic foot infection, like bacteroids, bacterial species, Clostridium, and anaerobic Staphylococcus, Peptococcus, Peptostreptococcus. And of course, 1.5% of the patient or the diabetic foot infection are because of the Candida or Fusarium fungi. There are different classifications of diabetic foot infections are there to select antibiotic regime. to prognosticate and to decide about the hospitalization. There are three main type of classification there. One is International Working Group on Diabetic Food, also known as PADI system. Second is IDSA, that is Infectious Disease Society of America system. And third is the simple clinical classification given by the Benjamin A. Lipsky, who is, I think, father of this infectious disease worldwide. And as far as IDSA, diabetic foot infection classification is concerned, TFI are classified into four. One is the uninfected, that means there is diabetic foot ulcer but is not infected. Mild means when infection is superficial, cell height is less than 2 centimeters. And the moderate means when the patient is systematically well and metabolically stable, but he has deep tissue involvement in form of muscle, tendon, joint, or bone involvement. Cell height is more than 2 centimeters. There is an abscess of ganglion. All these are moderately severe. And the severe variety of IDSA classification is when the patient is systematically toxic, is metabolically unstable, hypotension is there, tachycardia, confusion, super, diabetic ketoacidosis, azotemia, etc., etc. All these are features of the severe diabetic foot infection. You think you should know this thing, that diabetic foot infection like a tip of the iceberg. Only small part is visible. As you can see in this case, that this looks a very small abscess at the base of the third toe. But when we did the surgery, we had to open up to that extent. Similarly, in this case, the left side you can see it looks very small ulcer, but when you have to do the surgery, you have to open and you have to remove the second ray also, third ray, sorry. So always have a high index of suspicion. You might be saying that a small ulcer is there, but then just imagine and just think about how long or how deep it can be and how superior or how proximal it can be to the ulcer site. So be cautious. Now we come to the examination part per se. The tachycardia, hypotension, and pyrexia. These are the features of severe infection. You should remember that pyrexia may be present only in 50% cases. Number of times, what happens that the patient of diabetic foot ulcer is lying down straight, he's enjoying everything, and he says, "No, sir, मुझे कोई दर्द नहीं, कोई infection, बुखार नहीं है." You should think that a fever may be absent in 50% of the cases, right? You should remember this thing. So small breathing, of course, hallmark of the diabetic ketoacidosis. Then on examination, you can see cellulitis or lymphangitis, lymphadenopathy. This you can see a pinkish streak starting from the ulcer and going to the inguinal lymph node. This is also very important thing to be seen. Then, of course, you should see for an edema around the lower part of the leg or the foot or around the ulcer. Then color of the skin should be noted, whether the red, blue, black, which may be dry or wet gangrene. Then if you find this type of blister and if you touch it, there is a crepitus. That means there is a gas gangrene. This is a hallmark of it. And similarly, if there is a sinus, you should put the metallic probe. If it touches the bone, then the chances of getting osteomyelitis are 87% with sensitivity and specificity 83%. This is very important clinical test which you should do whenever the depth of the ulcer is more than its width. There are certain danger signs of diabetic foot ulcer. You are dealing with a diabetic foot ulcer patient. He keeps on coming to you frequently. And if either of these signs are there, so you should be cautious. Yes, now the patient ulcer is getting infected. What are they? Like if the patient starts feeling tired, weak, he's getting fever with chills, then there is throbbing pain in the foot, or the foot swelling has increased suddenly, and it starts smelling. As soon as you open the dressing, the room fills with the foul smell, foul odor, and foot color changes from red, blue, purple to black. That means the gangrene is supervening. And if there is blister or there is watery purulent discharge, that is also a danger sign of diabetic foot ulcer. That means the patient is getting infection in that particular ulcer. Now, what are the routine investigation? Here also very common tests which we do, TLC, DLC or CBC, complete blood count. You should know that the TLC may be normal in 50% cases. Again, because we see the report, oh, TLC is normal, no, bro, there is no infection. No, it may be diabetic foot infection because ESR also may not be increased. But of course, more than 70 millimeter mercury ESR is a sign of diabetic foot infection. So what you should do? You should go for a C-reactive protein, CRP test, which is almost always increased, particularly more than 10 milligram per deciliter is significant. It helps in finding out what is the severity of the infection and what to prognosticate also. This is today you do the CRP, you get a patient with diabetic foot. After 7 days of giving antibiotic or treatment, you find out again what is CRP. If it is coming down, that means diabetic foot infection is controlled. Otherwise, if it is increasing, that means the infection is increasing even after you giving antibiotic or taking all those modalities to treat it. Now, of course, hemoglobin should be seen for the anemia and ketones for ketoacidosis. KFT and LFT should also be seen because of the diabetic foot infection. The urea creatinine may rise and patient may go into liver or kidney failure. Now, how to diagnose the diabetic foot infection? You should remember this thing that it is not always microbiologically. It is most of the time clinical, right? So systematically, you should see if their patient has anorexia, nausea, vomiting, malaise is there, is having fever with chills. This is very common thing. You should ask the sometimes people no, sir, there is no fever. But if you ask it's still ठंड लगती है, हाँ ठंड लगती है. So you should be cautious. Yes, there may be infection. So chills are also very important symptom. And then if the patient is confused or tachycardia is there, if you find blood sugar very high, 500, 600 patients are up to 1 week back, my sugar was all right. Now it has gone 500. So what could be the cause? Then if there is a ketosis or urea creatinine has increased, and locally if you see there is ulceral sinus with the pus discharge, that is also very important sign. And if 2 or more than 2 signs of inflammation, which we have remembered by the acronym of PRISH, that is redness, heat, pain, swelling, or loss of function are there, then also there are chances that there is a diabetic foot infection there. But there is no doubt that the gold standard of finding out diabetic foot infection or confirming diabetic foot infection is a culture and sensitivity. As far as culture sensitivity is concerned, certain points are there which everybody should remember. One, if you find that the ulcer is a necrotic, it's a chronic, recurrent, not responding, and there is blackening of the tissue, then chances of anaerobic bacteria or foul smell, that is also the sign of the anaerobic infection. So always get aerobic as well as anaerobic culture sensitivity if you have these type of signs. And if the finding is more than 10 to 5, 10 to the power 5 organism per gram of tissue, then chances of infection there. And at the time of taking, you should remember that never go for a superficial swab. This is very common mistake, and it is made by most of the clinicians, even the very senior guys also, because of their busy schedule or because of unawareness or because of ignorance, I would say. So they take simple swab and send it, and it comes negative. But even it comes to, it gives the wrong answers. So always, first of all, do the debridement, superficial debridement, wash it with the saline, and then take a deep curate or deep tissue from the ulcer and send it for the culture. In 99% in my clinical practice, I've seen 100% this type of culture technique brings the positive result. You can find out the what are the type of the organism, and accordingly sensitivity can be found out, and you can start the antibiotic. So this is very important thing to remember. So at the time of operation, definitely deep infected tissue should be sent, which usually come positive if there is a diabetic foot infection. And if there is systematic toxicity there, so definitely you should send a blood culture sensitivity. As far as diagnostic imaging is concerned, most common test which we do is the X-ray. Depending upon the site of the ulcer, if it is the plantar, the forefoot is there, then get a X-ray AP and the oblique view. And if it is the posterior part of the foot, then X-ray AP and lateral view. You should remember this thing. But one thing you should remember that there it may be normal for 2 weeks, right? So these are the usually finding that there is osteoporosis with the surrounding osteosclerosis can be there, pathological fracture, then the loss of bone. These all are the hallmark of the osteomyelitis. CAT scan can be done, but the MRI is the diagnostic procedure. Why? Because it has a sensitivity of 90% and 80% of specificity. You can find out what is the depth of the abscess, whether the bone is involved or not. So MRI is the, I would say, the diagnostic procedure of choice for the osteomyelitis to be confirmed or to find out the extent of the depth of the abscess to be found out, because that picks up the soft tissue also. CAT scan is not going to tell you in more detail. Similarly, high resolution ultrasound sometimes can be done if there is a fluctuation. There is a liquidity, you can pick up with it, and then you can put a needle just to find out if there is a pus or not. And of course, radionuclide scan like indium 111 can be done. And if there is a osteomyelitis suspicion is there, bone culture and histopathological examination is the definitive diagnosis to find out if it is there or not. Now, friends, we come to the treatment of diabetic foot infection. Now, first of all, we should find out which antibiotic to be given, because diabetic foot infection, there the infection means antibiotics to be given, right? Now, there are certain points you should remember. What are the indications? So, should we give diabetic foot ulcer or diabetic foot ulcer patient antibiotic? This is wrong. If the ulcer is not having any clinical signs, symptoms of infection, never give it. You should remember, because what happens, the infection subsides to later in the treatment, but we keep on giving antibiotic till the ulcer heals totally, which is wrong practice. Because it has been seen that if the antibiotics are given without infection, so then there is a side effects chances are there. A lot of cost is also incurred, and chances of developing resistance is always there. So mind it. Now, which antibiotic to be given? To start with, here one I would like to mention, whenever a diabetic foot infection patient comes to you, first of all, clean it with the normal saline. Do the debridement, whatever you can do, and send the culture. Then put the betadine or any antiseptic, or otherwise what happens usually, as soon as the ulcer comes, we clean it with the betadine, etc. And then we take the culture swab and send it to the, which comes negative. So you should remember this thing by heart, that before sending the culture, never apply any antiseptic with the betadine or anything else. So to start with giving empiric treatment, ideally treatment should be according to the culture sensitivity report, but it takes 2-3 days. So you have to give some medicine. They are known as empiric therapy. There are certain principles of giving empiric therapy also. They should cover most common pathogens. As I told you, the gram-negative organisms are more common in India than the gram-positive, but definitely they are polymicrobial. So you have to give antibiotic which covers the most of the organism, or you have to give polymicrobial treatment is to be done. So narrow spectrum treatment should be given when it's a mild infection. If it's a severe and chronic diabetic foot infection, you should give always broad spectrum antibiotic, and try to include, as per the USA guideline or the Caucasian guideline, the antibiotics for the staphylococci and the streptococci. These are the different empiric antibiotic regimens are there according to Benjamin Lipsky. For the mild to moderate infection, cephalexin, amoxiclavulinic, clindamycin, diclofloxacin can be given. They are given orally for entire course. For moderate to severe infections, we give usually intravenous to start with, and later on, if the patient gets stable, we give orally, like MP sulfa, then Clinda plus Cipro, or linezolid plus fluoroquinolone, Pipra, Tejo, fluoroliver. These all are the drugs which can be given. Then for life-threatening infection, patient is in toxic state, then prolonged IV infection is to be given, like imipinam, silacin, clindamycin, tobramycin, ampicillin, Pipra, Tejo, Genta, meropenem, and different tegoprazole. But there are a number of medicines are there. If there is a clinical suspicion of MRSA, then you should give the linezolid or vancomycin. Then of course daptomycin, cunipristin, dalfopristin can be given. These all are empiric antibiotic regimes. Now, what are different antibiotic routes? Usually, the topical antibiotics are given for the mild infection, but there has been no published data. But lately, two local ointments have come in the clinical this thing scenario. One is the pexicanin acetate 1% cream, and it has been seen 85 to 90% clinical response has been seen. Another is Faspixon, which has healing rate of 60% in comparison to 35% in comparison to the other therapies. And this has been approved in a Korean this thing medical sciences. Even Singapore, Malaysia, they are using it also, but not been approved by the FDA. Now, oral medicine are they less expensive, more convenient. You should remember the list of these medicines. Good bioavailability even on oral route. Best bioavailability is linezolid. It is 100% bioavailable. Then comes the clindamycin, which is around 80-85%. Then metronidazole and fluoroquine. So if the patient is not vomiting, he is tolerating the medicine. So rather than giving intravenous linezolid, it is better to give orally because it reduces the cost and side effect also. Remember, these are very important pearls you should remember. If patient has severe infection or systematically illness is there, or patient can't take orally, or oral formulation is not, I would say, meropenem, imipinam, they do not have their oral preparation, so you have to give intravenous route. Now, certain non-conventional route I am telling you. Fourth is a retrograde venous transfusion. In cases of venous varicose ulcers, we give BP cough is infiltrated with thigh antibiotic, and it is given through the pressure into foot veins. And intra-arterial antibiotic given when the arterial ulcer is there or the wet gangrene is there. Then if there is a gap in the bone and it is infected, then you can give put antibiotic loaded beads for the bone cement. Just like Stimulan is available in the market. So these beads can be put in the bone space, and they are not absorbed. So gradually they fall down, but they give a structural support to growth of the tissue, and that's how the osteomyelitis takes care, because you can impregnate this stimulant pellets with the antibiotic also, say aminoglycosides, say micacin, etc. You can put. Now, the duration of therapy, this is also very important that it should be given. Normally, we give antibiotic course for the 5-7 days, or at max 10 days, or maximum 15 days. But in diabetic foot infection, the scenario changes. If it is mild to moderate infection, you need to give antibiotic for 1 to 2 weeks. If the more severe cases, you have to give antibiotic for 2 to 6 weeks. Sometime for the longer duration, as far as bacteremia is concerned, or the patient who cannot undergo surgery or who have a surgical metalwork at the diabetic foot infection site. And again, as I told you, that stop antibiotic if there is no sign symptom of infection. If the diabetic foot ulcer, you find there is no sign symptom of infection, then stop antibiotic. Don't keep giving till the wound completely heals. Then antibiotic choice, as I told you, depends on the culture and sensitivity. Once you get the culture sensitivity report, there are 3 scenarios. One, the lesion is healing and the patient is tolerating it. Never change the antibiotic according to the culture sensitivity report. Whatever antibiotic you have started empirically, continue with it. Don't change it according to the culture sensitivity report. It might be different. If infection is not responding, then change antibiotic according to the culture. Obviously, once you got the test report. But third scenario is not uncommon, that infection is worsening despite giving antibiotic of the as the culture sensitivity says. So you are in a fix. That patient was not responding, you started antibiotic according to culture sensitivity, but now again the patient is not responding. Then what is the possibility? Then there are chances that there is an anaerobic infection. So send anaerobic culture, or send it to different lab, or send again the culture, aerobic culture, and think of surgical intervention. There might be deeper abscess present there. So you are doing debridement, etc. on the superficial area. So think from that angle, get an MRI or CT, angio, or other test investigations. And MRI is the best to find out the deeper abscess. And there are chances of fastidious organisms also there. Those organisms who need special nutritional environmental requirement or media are required. Now, few words about the MRSA. This is not uncommon nowadays, methicillin resistant staph aureus. These are resistant to bacteria are resistant to beta-lactam antibiotic. What are the beta-lactam antibiotic? Penicillins like methicillin, dicloxo, naphthalene, oxalin, and all cephalosporins. And they have become a menace. You can see in USA also the graph is going up as far as MRSA is concerned. And they are merciless because incidence is increasing every year in high-risk group particularly. And it is associated with the longer healing time, higher amputation rate, and higher mortality. So that's why MRSA is in fact very important. And what are the antibiotics to be given? They infection-wise they can divide in two. One is healthcare related, other community required. In healthcare related, vancomycin is a drug of choice. But now there is a vancomycin resistant cases also coming. They are Versa. And if the community acquired MRSA is there, then you can give Clinda, fluoroquinolone, erythromycin, and rifampicin also. Nowadays, nobody gives trimethoprim and sulfamethoxazole because we have this safer drugs available. And if there is either of the two or Versa, then linezolid, quinapristine, dalfapristine, or daptomycin can be given. Now, few words about the osteomyelitis. As we know, they are just like the diabetic foot ulcer, they are polymicrobial. Different microorganisms has been shown. And preferably antibiotics should depend upon the culture and sensitivity report, but they should be given for the longer duration, as I told you earlier. And empirically give those antibiotics which have better bone penetration. Now you remember these antibiotics also, which are good bone penetration. You can note down also clindamycin, fluoroquinolones, macrolides like azithromycin, and linezolid. They are the antibiotics who have better bone penetration. They should be given to start with parenteral and later on can be shifted to oral for 6 weeks. And for chronic osteomyelitis, you should remember that you should remove the infected bone part. Because if the sequestra remains inside, that tissue, that bone is lying inside, it may not heal, whatever you do. So surgically, you have to remove that bone sequestra. Now, about the gas gangrene. Gas gangrene is a dangerous bacteria infection causing exotoxin-induced myonecrosis and gas formation within gangrenous tissue. You can see this type of picture is not uncommon in our clinical practice, the one who deals with the diabetic foot ulcer cases. So the presence of gas bubbles and crepitus on palpation. If you put your hand, you will find a crepitus there. This is the hallmark of gas gangrene. It is usually caused by the Clostridia perfringens, which is anaerobic, gram-positive, and spore-forming bacteria. Others may be Clostridia novii, anaerobes like Streptococcus, bacteroids, and Klebsiella pneumoniae. They also may cause the gas gangrene. On X-ray, this is the best thing to do. Even sometimes you pick up with the simple X-ray, and MRI also tells about the presence of gas bubble in the soft tissue. As you can see here, black spots on X-ray. And the drug of choice, antibiotic is penicillin plus clindamycin. That too in the higher doses as I've shown, and you have to give it sometime for the 1 month, up to 10 to 28 days. And if the patient is sensitive to penicillin, then you have to give clindamycin plus pipra plus stajo or cefotaxime or imipenem or ertapenem. So this is a very important thing to be remembered. And of course, you should debride and excise or ampute the part of the gas gangrene. Otherwise, it is going to extend or going to ascend very fast. And HBOT or hyperbaric oxygen therapy also has a very important role because it has been found to prevent the growth as well as killing the Clostridia perfringens. Now, after this, after giving antibiotic, you have to do the debridement of the ulcer. But there are certain principles which you should remember, because usually whenever we get diabetic foot ulcer, we go for the debridement. If there is cellulitis, never do any debridement. Another thing is the debridement of neuropathic and ischemic ulcers are different. And they should be repeated on every follow-up visits. And it has been found that if there is inadequate debridement, the infection is going to persist and it is going to be non-healing. So always do debridement thoroughly. Surgery should be reserved for the deeper and severe infection. And more important thing is prior evaluation of vascular status is must. Because if you are not going to open the anterior tibial, posterior tibial artery, etc., then chances are there that the whatever debridement has been done, it will fail. Patient is going to get it again because the vessels are not open. So whatever antibiotic, etc., you are giving, it's not going to the ulcer site. So it is going to recur and not going to treat. And similarly, if pus pockets are there, they have to be opened. Now, important next point is the mechanical control or offloading, which is the cornerstone of treatment. Patient should not walk because every step which he takes is going to spread the infection and is going to increase the diabetic foot infection. So no weight bearing ideally until wound is healed up. So what is the best offloading technique? Best is just lie down, complete bed rest, which is not possible. So that's why we give different offloading shoes, etc., which I'm going to tell you in another lecture. Now, next point is vascular control, because there's been seen if you improve the blood flow to ischemic foot, it controls diabetic foot infection. As I told you, that antibiotics can reach there, but you should postpone the revascularization until sepsis is controlled. You remember? So first of all, take out the pus, then do the angioplasty or bypass next day, something like that. Then comes the metabolic control. This is also important. You do whatever, but if you're not going to control your blood sugar of the patient, then probably the ulcer is not going to heal. So take care of that. You can refer it to diabetologist. And if there is dehydration or diabetic ketoacidosis, take care of it. Hypoproteinemia and nutrition to be looked after. So to summarize this talk, foot ulcer and foot infection are the commonest cause of hospitalization in diabetic. Diabetics are prone for diabetic foot infection because of immunopathy, neuropathy, vasculopathy, over and above unique anatomy of the foot. And never take superficial swab. These are the pearls you should remember. Always go for deep tissue culture sensitivity. And in diabetic foot infection, fever may be absent, ESR may be normal. So get a CRP done. And broad spectrum antibiotic for longer duration. This is the principle. And recognize the emergent surgical situation which I have enumerated. And this is the triad of controlling diabetic foot infection: debridement, antibiotics, and offloading, other than blood sugar control. And you should remember by heart that the minor diabetic foot ulcer may be infected and they may ultimately lead to amputation. So be cautious. Thank you very much.